Good evening, all of you, and we welcome you all to this 8th lecture on Precision Oncology Asia webinar series. Many of you would have been regular attendees to this webinar series, and for those of you who are new to this forum, a brief introduction. For Base Care is a precision oncology company, and Precision Oncology Asia webinar series is our effort from For Base Care in terms of bringing together experts from the fields of basic research and clinic to come together and share their knowledge and experience in how precision oncology is practiced in clinics today. It is my great honor to welcome today Dr. Sewanti Limaye, Director, Precision Oncology and Director, Clinical and Translational Oncology Research at Kokilaben Dhirubhai Ambani Hospital and Medical Research Institute at Mumbai. Prior to this, she served as Consultant Medical Oncology at Dana-Farber Cancer Institute, Harvard Medical School, Columbia University Medical Center at the United States. Dr. Sewanti has more than 2 decades of experience in treating cancer patients and has a great passion for translational research. Her interest in translational research has always been towards the development of novel therapeutics in solid tumors. I would not take much time of you and hand over the stage to Dr. Sewanti. Over to you, Dr. Sewanti.
Thank you, Vidya. This is a pleasure and an honor to be speaking here today, and obviously one of my areas of interest, which is genomics, cancer genomics, and precision. And when I talk in such forums, I always like to put forward how the learning has happened. And I'm not professionally trained for this. More so, I'm a clinician with an eye for genomics. And that I've been fortunate to have right from the start because of my exposure. So, what India is seeing today, I was privy to this 15 years ago, and the challenges that come with it in trying to unravel the test results and to implement it for our patients. And one of the biggest challenges that a clinician faces is when you are faced with a patient, how do you do the right test? How do you do justice to the patient in trying to figure out what will be the best treatment for them? So I'm just going to start with an example of a patient that I have in my under my service admitted today. So she is a 50-year-old who has been brought to me from outside of Mumbai, who has leptomeningeal disease, who's a non-smoker. And we have done now, in between the oncologists in Baroda and myself, we have done at least 3 NGS tests, one blood-based, and we still don't have a driver mutation. And I can tell you that in a leptomeningeal patient, the only real chance is if we were able to find a pathway-driven lung cancer that could be targeted with a drug that could penetrate blood-brain barrier. And so the test methods become very important. Once you have the test method done, taken care of, you at least know that you've done the right test. You've explored the patient inside out. When your clinical suspicion is high, you really need to get the best test done so that you can do justice to that patient. And then application of the result obviously involves the right drug for that patient. So that's just a segue. And with that, I just would like to put forward a platform where I feel I am only as smart as the diagnostic test I do. And once I have the results, obviously awareness of what's to be done with that test is also very critical. And so we'll talk about that as well. But to begin with, the test has to be done appropriately. And once the test is done, you figure out a pathway that could be hit. I think that's really a jackpot that the patient hits. And as a treating clinician, there's no greater pleasure than that.
Yes.
That said, I think we are talking about NTRK today.
Yes.
And it's really the call of the time, because I know there are 2 drugs in pipeline that are about to come here as well in different capacity. And so all the more reason for us to be testing and be aware and be able to offer that as a pathway coverage for our patients. If it's okay, I will start my presentation, or would you like to say something before that, Vidya?
No, you can start. I think we have good number of attendees already here.
Okay.
You with no delay, we can start the presentation. Thank you so much.
So we are here to talk about NTRK fusions, and I will navigate through this as I understand from a clinician's perspective what are the various testing methods. First of all, what is it? What does it mean? How does it participate in oncogenesis? What are the various testing methods? And what are the drugs involved? Where would we use them? And some of my personal experiences with this pathway. So when we talk about NTRK fusions, we just have to understand that it exists in a very wide variety of solid tumors and hematological malignancies. And the index of suspicion in a particular tumor actually directs the testing method, and I'll come to that in the later slides, because we really need to understand how high our suspicion is. Is our suspicion high enough to do a particular testing versus the other? So here, if you see, there are a whole host of malignancies where it is described. And it could be from anywhere less than 1% in the routine malignancies like breast cancer, pancreatic cancer, melanoma, and colorectal cancer. But I just have a submission here that for a patient who comes to me with colorectal cancer, is NTRK not important? No, I wouldn't put it that way. Even when the percentage is less than 1% mentioned here, for that patient, that's the pathway. If that patient were diagnosed with an NTRK fusion that was targetable, for that patient, it's such a critical pathway. So yes, testing method has to change, but the importance of the pathway doesn't go down. Similarly, when you look at thyroid, certain GIST, other tumors, the rates could be higher, significantly higher, and up to more than 90% in very, very rare tumor types. So one of the very basic ways that I remember, the rarer the tumor, the more you look for NTRK. The commoner the tumor, the less chances to find NTRK. Still, as as a person who follows cancer genomics, really I set out there to track and try my level best to understand the tests, because the test that I'm doing should suffice, should be able to give me that answer. Is it giving me that answer? And if I don't get it, what do I do? I should then at least know a better test and know how to get to that test to get the answer. So looking is critical. Looking for NTRKs is critical, is the message that I would want to bring here. So again, rare cancers, when we talk about rare cancers, all of us as treating oncologists see certain common cancers that form the major pool, and then every so often there'll be a rare cancer. When we have a rare cancer, the chances of such esoteric pathways are real. And that's where doing a test that may be different comes into play. And so trying to at least keep a go-to slide set or a card wherein you would be testing for this may be meaningful. So I have an NTRK card. And, whenever I have a rare tumor, I definitely look at that to try and figure out, if this patient can afford, what testing should I ask the patient to get. When we are looking at common cancers, and later in the slides, they're actually very nice way of studying common cancers. So you look at what's to be done for that common cancer first. You don't think NTRK. You think what's more common. So for a lung cancer, I'll think EGFR first. And so for us in India, where testing methods may not be that prevalent, we have to go through it sequentially. And that's where tissue preservation may also become critical. So for more common cancers like lung cancer, where NTRK gene fusions are rare, you have to go through the algorithm of testing. And you do the tests that you find more meaningful. And then you look at tests that may still yield when you're not able to get that result. So for the case that I just briefly mentioned, it warrants, it really warrants to look deeper, because my clinical suspicion for this person having a driver mutation, lung cancer, 50-year-old, female, Asian, is very high, non-smoker, very high. And so I have to examine my testing method. And if I'm not doing the right testing, then I may want to revisit that and really look into that. So if you see here, this is a slide that tells you a frequency going down, wherein you have different kinds of cancers mentioned. And really, this is a go-to URL or a link, where if I had an intrahepatic cholangiocarcinoma and a 3.6% chance of NTRK1 fusion, it is something that I would take seriously, because you have to think of comparative numbers. So when you think of ALK in lung, we're talking 5 to 8%. So if ALK in lung at 5 to 8% is so important, if ROS1 with 1 to 2% is so important, then NTRK1 in intrahepatic cholangiocarcinoma, which is a serious disease with very high mortality, is really a jackpot, provided we have the drugs. And that's what I'll come to at the later end of the presentation. When you have solid tumors and liquid tumors aligned, and you know what frequency you're looking for, you really understand the value of the testing method. So I'm just going to give you an example here. So let's say I have a papillary thyroid cancer patient, and I looked. If I looked and I didn't find, how hard should I be looking? And what kind of test does it have? NTRK 1, 2, 3, and the different kinds of NTRKs that are listed here. Those fusions, does that test involve the exon, intron, what all portions are being covered? That understanding is something that we have to build over a period of time. But in general, having a generalized idea of representation in a particular tumor is critical, because if you see here, just look at the congenital fibrosarcomas and the frequency that is mentioned, extremely high. So that's a patient. If ever you were to get a patient, I haven't, but if ever you were to get a patient like that, it should just ring NTRK. So that's where, if you don't find it, you've got to look differently. But in a thyroid, we know that the percentages are low. So as long as your testing method is right and you didn't find it, you really didn't find it. So I have a different outline of the test methods and what all they do and what not. And the reason to really put this slide down here is that each testing method will have a variation. It's very critical to understand the variation and critical to understand what all are you testing. It's extremely important to know your testing method because this test is complex, and I'll come to that in a second. So when we talk about NTRK receptors, these are receptors that are tyrosine kinases that are activated by ligand dimerization. So you see that there is a ligand dimerization happening here. There's an extracellular domain for the ligand binding that is here, and then a transmembrane region and an intracellular domain with a kinase. Once, like in all receptor tyrosine kinases, the binding of the ligand to the receptor is triggering the oligomerization of the receptor and the phosphorylation that you see here, and the downstream signaling for proliferation and oncogenesis, survival. In sync with that, there are 3 genes, NTRK 1, 2, and 3, and they lead to 3 transmembrane proteins, TRK, TRKB, and TRKC. And one of the things that we know here are that the TRK proteins are in abundance in the nervous system. In the non-neuronal tissues, the TRK proteins can be seen in cardiovascular, reproductive, endocrine. So these proteins are there in other areas other than the neuronal areas as well. And they regulate proliferation, differentiation, apoptosis, survival. And this is a very well-known mechanism of propagating survival in the routine working of the cell. Formation of the complex comprising of the ligand and phosphorylation of specific tyrosine residues of the intracellular domain will activate these pathways. And we can see the downstream pathways, and we know that these are the pathways that are active for oncogenesis, proliferation, and survival of the cancer pathways. So when you get NTRK gene fusion, they cause ligand-independent activation of downstream signaling. And there is a transmembrane, and there's a kinase domain, and then you have the activation of the downstream signaling as soon as the fusion happens. So when you have the wild type protein signaling, which is ligand independent, versus the fusion oncogene signaling, which is ligand, the wild type protein signaling, which is ligand dependent, versus the fusion oncogene signaling, which is ligand independent, and you don't have a ligand, this is like ever active. And you see this activation of downstream signaling that happens. So in the fusion that forms with the NTRK and the partner gene, you have an independent on signal that goes on for proliferation. And that's where the oncogenesis is happening in presence of the NTRK fusions that have been cited. The drugs that inhibit activation of the NTRK, the drugs that, the TRK inhibitors that inhibit the activation of the TRK signaling are actually binding in the tyrosine kinase domain. And they lead to inactivation of the downstream signaling, leading to stopping this autonomous ever active pathway, causing carcinogenesis, limiting survival and proliferation that is NTRK induced. So this is the fusion partner, and this is the tyrosine kinase domain of NTRK, and then you have the TRK inhibitors that inhibit the downstream signaling. So we understood that there are 3 genes, lead to 3 proteins, and they lead to ever active downstream signaling when in presence of the fusions that happen. And when you have an inhibitor that acts on the tyrosine kinase, it leads to inactivation and stoppage of that pathway or inhibition of that pathway, leading to stopping the proliferation and carcinogenesis that happens as a result of the NTRK fusions. So when we, as a regular person, I need to understand the fusions and how they align. So we have base substitutions in mutations, like routine point mutations that we talk about. We have indels, which are smaller insertions and deletions that are happening. We have copy number alterations, and we have rearrangements. Now, when we talk about fusions, the fusions can be a structural rearrangement, as is seen in here, or transcription or splicing that leads to the fusion formation. What's happening here? Here we have the NTRK1 gene, 2 and 3, leading to tyrosine kinase A, B, and C. And when you look at the protein for NTRK1, it's tyrosine kinase A, and you have the extracellular transmembrane and the intracellular portion. And when you have the NTRK gene fusion, the true NTRK gene fusion, then you really see carcinogenesis happening. So you need to have this, the entire mechanism. One of the commonest fusions found in lung cancer, TPM3 and NTRK1. So you see here gene 1 and gene 2, and then you see the DNA breakage and the flipping happening, and then the rejoining. So you have the fusion oncogene, which is TPM3 and NTRK1, and then you have the protein with the help of this, which is TPM3 and TRK-A. That's the fusion protein. And that has to be in frame. So there's this concept of in frame versus out of frame gene fusions, and they each come with a meaning. And as long as the in frame gene fusion is seen, this will produce the right kind of protein. So the fusion protein will be correctly expressed. As long as the fusion protein is correctly expressed, it leads to, this is actually contributing to carcinogenesis, versus when you have out of frame gene fusion, something that I learned, as I read more and more into this. When you have an out of frame gene fusion, the fusion protein will not be functional. And so in that patient, if you give an inhibitor, it may not work. So it's been found that it's actually these guys who have the in-frame fusion where the inhibitors really do the trick. The out of frame, and actually it's really like this flow chart, out of frame mutations, you need to check for protein expression using IHC to confirm whether giving them inhibitor is really going to do the trick. So in frame versus out of frame, very, very critical and important to understand. And here's a list of partner genes with NTRK1 and NTRK2 and NTRK3, and how the in frame and out of frame are understood and correlated with response to therapy. NTRK gene fusions will cause constitutive activation or overexpression of TRK proteins. We already know that. So how is that utilized in the diagnostic methods? Is mainly that in certain tumors, you can actually take a two-step approach, and I'll come to that in a second, wherein IHC-based approach could be used as a screening, or it could be used as a confirmatory tool in conjunction, in parallel with the NGS testing. And utilize the IHC-based method wherever you're utilizing it, either for screening or for confirmation. You know that these patients are the ones that are going to be able to respond to TKI-based therapy. So, like I said earlier, there are multiple NTRK fusion partners recognized. I believe there are like, so 60 and multiple tumor types. So you know that this pathway is tumor agnostic. Some of the pathways in oncology are tumor agnostic, and we really need to understand those that are not tumor agnostic. The ones that are considered tumor agnostic, in that NTRK is one. So it is a pathway that I try to remember across the patient types that I see. It's really being unjust to the patient if you're really out there on a fact-finding mission. Sometimes I think of myself as being a detective. You didn't find it here, you need to figure out the next method to find it there. You need to figure out the next method after that. And so there are some patients who are with you. They will walk with you. So you need to get your answers straight in terms of what tests you're doing. And tests should be able to cover largely, they should be able to cover the common fusions that are enlisted. Very critical. You need to ask the question whenever there is a testing method presented, whether these are being covered. And the reason to do that is because of the heterogeneous nature of the fusions that is demonstrated here. So knowing the algorithm, knowing the tests is critical, and which patients you are testing in. So there are certain recommended methods of testing, and MSKCC has its own, ESMO has its own, and varied ways. Most recommendations actually touch upon the RNA fusion testing, the FISH and the PCR-based testing, the IHC testing. How you do it is what depends on which tumor type you are testing, how high your index of suspicion is, where are you doing NGS-based testing in such a patient. So I like this slide because if you look at it here, it's histology-based triage. So if you have a high suspicion, what do you do then? So here they are suggesting if you have a high index of suspicion, you can actually start with a pan-IHC, pan-TRK IHC. Now, I will just, this is a disclosure right here, that these are methods that I'm describing. It doesn't mean this is what one is recommending. It's about these centers. This is how, their pan-TRK IHC is very developed. I'm not sure how many centers here have a pan-TRK IHC. When we did the Roche meeting and we had a lot of pathology representation, not a whole lot of centers had idea. I mean, people didn't even know how much the TRK IHC testing dye was going to cost. The reagent was going to cost. So I'm just saying that these methods are not standardized at certain places. And so you've got to know your center well. So here the recommendation is to go with carcinoma pan-TRK IHC, or in a sarcoma, do a FISH or an RNA level fusion testing in low pretest probability. What does that mean? So for example, lung cancer, colorectal cancer, right here, genome-based triage. So you do what you need to do for that patient. So for the lung patient, whatever you need to do in terms of whatever test you need to do, you do that. And then if your index of suspicion is still very high, you need to dive deeper and include other tests. So as a routine, I mean, since a lot of fusions have been described and lots of drugs have come in, I think as a treating clinician, I have moved just from a DNA-based test to also incorporate RNA-based test, mainly because of this, that you have limited fund for testing, you have limited tissue for testing, and you really may not get a second chance with the patient. You really may not be able to test again in a longitudinal way. So you need to ask your question at the outset if you can. If you can be mindful and ask your question at the outset, that would be really nice. A lot of us are not able to do it, and that is okay. In that case, you could still do it in a longitudinal way. This is another recommendation from ESMO. That was from the earlier one was from Sloan Kettering Cancer Center, which is in New York. This one is from ESMO. And in the ESMO recommendation, if you see here, scenario 1 and scenario 2. Scenario 1 is the tumors with high occurrence of NTRK fusions. And so they say, okay, you can do a FISH where you need to have, you really need to know the partners, or RT-PCR, or a RNA-based sequencing method. And scenario 2 is when you don't have, you really don't have a high occurrence expectation. So pretest probability is low. And in that case, you look at whether or not you have capacity to do RNA-based testing. And if you don't have the capacity, then you do IHC and regular NGS. And if you do have the capacity, do frontline NGS, which also includes RNA-based. So a lot of different methods and recommendations and a knowledge of what you're seeking. So when you do an RNA-seq NGS, the sensitivity and specificity for this kind of a testing will be high versus DNA-based, which is moderate. And again, there's something called hybrid NGS, where also you're looking at the partner fusion gene, and there also you're able to pick up. IHC, on the other hand, has high sensitivity, but specificity could still be moderate because of what I described, that there are other tissues where TRK proteins can be expressed. So the other thing is to understand which NTRK. So if you look at the pan-NTRK IHC, this is very complicated, and it takes a lot of time involvement to get it. So if you look at which NTRK, so NTRK3 actually has really compromised sensitivity. It's 79% versus NTRK2, which has 100% in this particular study. And duplication of this is required. So wherever you are doing the testing, that center has to be able to duplicate this kind of data. Otherwise, your rates are not going to be similar. But what's the data? And this data is from MSKCC, and they have tested now 30,000 cases. And here also, if you see NTRK1 is higher, NTRK2 is the highest, and NTRK3 is the lowest amongst this. Again, tumor variability. That's also something to be kept in mind. So different tumors have different kinds of sensitivity and specificity. And this slide actually speaks for that. I'll skip this slide because it's not exactly my forte. And so when you look at the FISH testing and the RT-PCR testing, again, the realization for FISH, you really need to know the partners. In the RT-PCR also, both fusion partners and the exon breakpoints you have to be aware of. And because of the diversity of the NTRK fusion partners and the variability of the breakpoints and the exons involved, the reliability of this will be questioned all the time. So you think of DNA and RNA. And so when I really wish to go deeper, I wish to think RNA fusion techniques are superior. Now, great. So why can't we do RNA testing for all? So we know that fusion calling will be superior when you're doing an RNA-based technique. But the downside is RNA is less stable and therefore more susceptible to degradation. So if you have an archival tissue, you may still miss. So these are understandings that one should really build over time and know when we are applying it in an interrogative way for a patient, where you're trying to understand which test to do, when to do, and how to interpret that test. And similarly, when you look at the tissue and how much tissue is involved, this is a generic slide which kind of tells you what all will be needed, what's the turnaround time. And most of us find the issues with NGS limiting because of the TAT. I hope and wish that with increasing numbers of NGSs that are being performed, very soon we will have short TAT for most of our patients. But it is a challenge. It's been a challenge over the last decade, and I see that challenge still there. Having said that, I'm pleasantly surprised by how fast things have moved in India and how fast things are catching up. And I really feel that it's a matter of a year or two when the TATs will really come down significantly. For now, if there is an IHC based method, we really can get the TAT down, our answer down to 1 to 2 days. And we all know that. We've seen with multiple IHCs and including PDL1s that we have now been doing, that if this were a confirmatory way, really, it was actually very quick. So when we look at the NGS based testing and how the NGS has evolved, one of the things that really stands out for me is my possessiveness for the tissue and to preserve that, to do the testing all at once. If we have done something in a longitudinal way and the tissue really runs out, and then you want to test for something by NGS, you may become limited. So up to IHC, I'm okay, but really if I'm thinking hard and I want all angles covered, I would actually preserve tissue, inform the testing center that this is time sensitive, and get my sample out with a TAT expectation that could be tight, and understanding fully what the test involves, so that I conserve the tissue and ask my question in one go. And the preference obviously is to do a DNA as well as an RNA based test, anything that covers both, basically, to be able to cover the fusions, mainly because it's, like I said, it's one chance. Yes, these methods are expensive, so cost is definitely a challenge. And going forward, the volume of tests we do will actually depend on what cost we bring our comprehensive NGS tests down to. Having said that, I see a huge movement in India, and the tests that were really earlier appearing to be unachievable have become a reality and affordable for a lot of patients. And I think earlier we thought middle class, it would be difficult to get an NGS test that was comprehensive, but really I have to commend Indian labs to make that happen. And today I have been doing comprehensive testing in Indian based labs for most of my patients. And that I feel is a huge leap for us treating oncologists in India. The IHC based testing is a Ventana pan-Turk assay, which again, we have to really educate our centers to have this, to validate it, and to keep it ready. My center specifically does not have it, and so that remains a limitation. And right now, for me, I am actually doing NGS-based analysis only. I'm not able to do a confirmatory testing or a screening test with IHC. However, I have been on discussion panels for clinical trials with TERK inhibitors. And really there is a push for Indian labs to start doing screening TERK analysis. I am aware of 2-3 labs where the discussion is happening. And I can't name the company or the drug involved, but involved in as a think tank in the early phases of discussion of trials in this space, and looking forward to more labs doing both IHC based testing as well as RNA fusion analysis for NTRK. So where we are, once we've found out that we have the pathway active in a patient, so NTRK gene fusion positive non-small cell lung cancer, we have 2 drugs that we can go to. If we didn't start anything and we found them to be NTRK positive, we have larotrectinib and entrectinib. And now we have a tumor agnostic presence of NTRK inhibitors in many, many different cancers. We have Roche providing compassionate access to entrectinib for NTRK fusion positive patients. And we have Bayer coming in to the country with larotrectinib trials for multiple malignancies, which we really are looking forward to. And when you look at this slide and the waterfall plot and the responses, it's across different tumor types. And that's a message that we need to carry, that this is a tumor agnostic pathway that is active in many, many, many different cancers. Where found, you have the drugs. Getting access to the drugs today in India is a challenge. So either it's a compassionate access through Roche, or down the line participation in clinical trials. A lot of my patients are actually able to have either a clinical trial, international clinical trial access for other drugs. I'm not just talking NTRK, or they're able to import. So one of my pushes is to understand where these trials are running. Where can I get my patient to? And awareness of what drugs are available in India, awareness of what drugs are available as compassionate, or what drugs are available in clinical trials in the countries in the vicinity becomes very critical. Clinical trial presence in India is also increasing. We are at Kokilaben Hospital, we are running multitudinal trials, and we have many, many trials that we have filled out feasibility for, and trials that are coming through and in various stages of ethics approval. So I mentioned this because this pathway is a novel pathway. We have 2 drugs, but we have many more drugs coming through. And we will see these drugs in development as we go along in form of clinical trials. One of the ways of bringing novel drugs to cancer patients worldwide is to participate as a center in clinical trials. 5 years ago, when I was coming back to India, I asked to really be a clinical trialist, and I was told there's no such job. I have to say that 5 years later, we've now run 20 trials at the Kokilaben Hospital, and we have many more in pipeline, including the Bayer larotrectinib study, which is in a submission mode. So I say this mainly because if you look at this slide, larotrectinib and entrectinib, these are the drugs that we are talking about right now. But then you have the other 2. And the ticks that you see as the generation of the drugs increases, these drugs become, in general, they become more active and less toxic. That's the way drug development happens. Once you crack the pathway, then you go after the finer points of the drug. So some drug will start to penetrate blood-brain barrier. Some drug will become more tolerable. Some drug will become more efficacious. So there are many, many areas where they improve the molecule. And that's where you need to know what's the next generation and where is it, and can we bring it in a clinical trial to our center. So that's always my lookout. I keep looking for the next trial that may come in. And so my last few slides, so if you see here, it's a wonderful time for oncologists, and especially if you treat lung cancer, it's a real happy time because there are so many pathways and some not even mentioned here, and many, many drugs. And so this patient with, just the last slide with entrectinib, you have a complete response for this patient. And that's what an oncologist is really looking for. So my summarizing last few points, and I think we've touched upon several times, testing method is critical. Where you need to look deeper is critical. So understanding the tumor biology, which cancer, where do you need to really have a higher index of suspicion? Is your test covering largely the fusions that we are looking at? Which fusion have you found? What does that fusion, the partner gene and the NTRK gene, what does that mean? In frame, out of frame, wherein you know that this is a pathway that is going to be active. And if it is an active pathway, where to get your drugs from? Can you get a compassionate access? Do you need a clinical trial? Do you need to import your drug out of pocket? How do you want to do it? And if you don't have access, how do you treat your patient then? Because one of the things that remains with us as oncologists is whether you have the drug or not, the patient is still yours. So you have to find the solution for the patient no matter what. And with that, I end my talk and I open the floor for questions. I hope I was able to impart some of the knowledge that I have for NTRKs. It's a complicated talk, but really enamoring because we are looking for pathways that we can target, and what's not to know something that works so well and is across tumor types. So thank you, 4Base Care, for having me. And I hope I was able to impart some of the nuances. Thank you.
Thank you, Dr. Sewanti. It was a very informative and very nice educational session. We have learnt a lot from this session, actually. And the good thing is you have described all the different technologies, how each one has an advantage over the other in a limited setting, how one can use that, and where you have, the patient has money and there is no dearth of spending money, how the patient can afford to go for a better technology and testing. It's a really nice presentation, and we thank you once again. So we have a few questions for you. I would like to start that if you're.
Yes, please.
Yeah. How NTRK expression or detection is different in terms of frequency in Indian population versus American population? Do you have it?
That's a very good one. I love it. So I'm laughing because, when I was doing the rounds for bringing the one of the trials to India, I really went to several different genomic companies. I have to tell you this, and I asked around, what method do you use? What's your number in the last year? And really very low numbers. People were not even testing. So I think the comparative numbers are non-existent. Really, with such low numbers, we cannot compare. Having said that, I am an optimist and a believer. So precision is a cult, and I'm a believer in this cult. So I really hope, you look at the pathway and look at that one patient who needs one chance, right? And look at the drugs. The drugs are so amazing. They are like oral drugs. The drugs can, most of these drugs are extremely good in terms of tolerability, quality of life, penetration in the blood-brain barrier, brain penetration. So what's not to look?
True.
The bottom line is what's not to look, but the comparative number between India and abroad really fall short right now. And it was pandemic time, so I can give the companies that, but I really spoke to many, many companies and I came down with very small numbers. So I think that uh, comparison is still uh, not not existent. But with the drugs coming in, I think more of us are beginning to look and explore, and very soon we'll be able to give out our own numbers. And I'm sure you guys are looking.
Yes. In fact, in the last 6 to 7 years of NGS panel testing, I came across one patient,
Yeah.
infantile fibrosarcoma.
Yeah. Congratulations. That's a
ETB6
find.
NTRK3.
That's a find. That's a find.
So now the next question is, between NTRK 1, 2 and 3, NTRK 2 has highest sensitivity and specificity for the IHC testing. So do you think NTRK 2 was the most, which is the most tested for? So,
So, when you look, it depends on which testing method we are using, right? Vidya? If you look at so MSK Impact. So a lot of us end up sending to MSK Impact. Why? Because one of the things that is cited is MSK Impact has NTRK3 exon and intron testing, and a counterpart of yours does not have intron testing for exon 3. So a lot of these things are nuanced. ISC based, yes, NTRK2 has very high sensitivity in that study at MSKCCE, but it depends on whether we are able to duplicate that data when we do our testing method here. What our validation numbers is going to look like, and each center is going to have their own sensitivity and specificity. So a lot of these things are subjective. I wish there was an objective number. Having said that, one submission is there. Not testing versus testing with IHC. Still, the percentage is quite high. Even if I took the least number, which is 80%, and thought all of these will come at 80%, still 80% possibility of something is significant. So my push is to do any of the methods, but do it. Be oriented towards trying to find it. Be sensitive to the test options that are available.
okay. Then another question: entrectinib is more toxic than larotrectinib. What
So
is your comments on this?
So I would say that the toxicity expectations are slightly different. Having said that, I have used entrectinib. My patient has done well on it. When you look at the comparison between the two drugs and chemotherapy, is what most of these patients end up getting, because if you don't get an NTRK, you're not getting anything else, and you are ending up with routine chemotherapy. In that regard, both the drugs are a blessing. The differences in side effect profile between the two are nuanced. And so I wouldn't want to pitch one drug versus the other. I would rather pitch these two drugs versus chemotherapy.
Okay.
And really, when you look at the tyrosine kinase inhibitors, these two drugs come in as a blessing. Having said that, it is a fact that larotrectinib is slightly better. When you look at the repotrectinib, which is the next generation, it's even better. So as the drugs are developing, we will see this change and improvement in tolerability for our patients.
Okay. So you mentioned about NTRK fusions in hematological malignancies as well as in solid tumors. There is so much which we are talking about NTRK fusions in solid tumors. Not much is being heard on hematological malignancies. So, what would be the frequency of NTRK fusions in hematological malignancies?
So that's a great point. The reason why we generally don't test in hematological malignancies is because we have mostly concentrated on um, a larger vision for heme malignancies. When you have a heme malignancy patient, you really are looking at uh, AML, ALL, largely the chronic leukemias and the myelomas and the lymphomas. When we are studying the lymphomas or myelomas, today the treatment options are far better and the survivals in general are really significantly higher than what we see um, in solid tumors, because solid tumors really, you don't have single pathway driven cancers. In liquid tumors, a lot of these tumors, even if they don't have single pathway, they are with current standard of care therapy, their results are really good. When you come into the acute myeloid leukemia portion where the results are not that good, there are some explorations. NGS in general is just being explored in hematological malignancies. I mean, I see the first few presentations happening, and I hound my. So I don't do hematology and I don't do hematological malignancies, but I hound my guys here at Kokilaben saying, why don't you guys do it? Aren't you going to? Don't you guys have things that you look out for when you do these? But the submission to that mostly is that they have other solutions. Having said that, I think acute myeloid leukemia and ALL, especially if you have Philadelphia positive ALL, those are areas where NTRKs have been reported. In that, one of the papers that I just showed had two cases where acute myeloid leukemia patient had NTRK fusion, NTRK3 fusion seen, and similarly an ALL patient. One around 150 ALL patients were screened and one had. So you're talking about low numbers, but low numbers is okay. We look for low numbers. Even in head and neck cancer, in that paper, the rate was 0.2%. But still, head and neck is a recommended thing. We don't necessarily look in liquid tumors. And my understanding is mainly the reason why we don't look is because we have other options which we don't in solid tumors. But I think the field is moving, and even in liquid tumors, we are beginning to see data presented for NGS testing and molecular profiling.
And what would be the survival benefit in entrectinib in cholangiocarcinoma? You have any comments on this?
So I'll take you back to generic precision-driven trials. So I don't have data in NTRK in cholangiocarcinoma. We will have that, right? But when you look at pathway-driven therapy, especially in tumor-agnostic pathways, pathways that show response, putting together, we have more than 1,000 trial data in the space of precision oncology, where PFS, progression-free survival, and overall survival advantage in meta-analysis, in several meta-analysis, has been proven. Now, the critiques of precision will say these benefits are limited. You guys talk about 6 months of benefit. You guys talk about 7 months of benefit. Drugs are so expensive. I submit to that. I totally submit to that these drugs are very expensive. So if you have a drug that is costing you 5 lakhs a month, it's unthinkable for large populations in the country. I think for 99% of population in India, that's not thinkable. But that doesn't mean that we won't look for a drug that is even 3,000 a month. What is happening is, in the precision spectrum, we are actually not even looking at the drugs that are cheaper because the other end of the spectrum is expensive. So answer to the question of cholangiocarcinoma survival in, specifically, one wouldn't know because NTRKs are so rare. You would only have anecdotal reports.
Yes.
But when you have pooled data for precision guided trials across the board over the last decade, people who went in pathway driven therapy lived longer than non-pathway driven therapy for advanced cancers.
True.
This is the bottom line for now, but I do feel that precision has to move upwards. Precision has to move in early stages. Precision has to move in diagnostic techniques. Shouldn't just be left to stage 4 cancers where things are difficult.
So one last question. It's already crossing 6 o'clock. If you don't mind, one question.
Please.
So do you believe in whole exome and whole transcriptome based approach for genomic profiling to detect not just the NTRK fusions, but in general driver mutations? And then do you feel that a reflex testing by other standard clinical testing methods which are accepted in the clinic today is required for clinicians to put that into their routine practice?
So wonderful question, Vidya. You've just asked me what I, would say from my heart. So I'm not going to give you a short answer. I'm going to give you a little long-winded answer. So 2009, hallway of Dana-Farber Cancer Center, asking for a onco panel, 40 gene, and the researcher says you'll have to, each sample will cost you $1,000, and it will be an expensive project. You have to seek funding. Okay, fast forward to where we stand today, where we can, for that kind of price, do a whole exome, or a comparable price, do a whole exome.
True.
My submission as of today, and I was in a long meeting, when you called me, I was in a meeting with my pathology team. They were asking me if the 15 gene panel is worth anything. I said, I won't do it. I won't do it. So my reflex testing is broad panel. My reflex testing is the broadest that we can get. And the submission should be to improve our testing methods, reduce our prices, but broaden the lookout, do it in the first go. Let the patient suffer less. Figure it out right up front so that you test and you have the answer and you treat. Empower yourself and empower the patient for better treatment and earlier treatment so that they can live longer. So that's my submission to you. And so the answer is yes. Whole exome, whole transcriptome, earliest that you do. And broad panels, as I arrived in India, I thought, how am I going to be able to practice my science? And I'm so overjoyed to say that over these 5 years, there has been such a movement in cancer genomics that here we are today talking about whole exome and whole transcriptome, and my full vote to that, and to do it as a reflex testing and to make it, and that's a request and an appeal to companies like yourself to make it more affordable for the masses in India.
Yes,
so
we are
thank
here.
you so much for the opportunity, and I'm so happy that I was able to talk about the subject that I love the most.
Thank you so much, Dr. Sewanti, once again. And we are really eagerly looking forward to work with you in many more exciting collaborations.
Absolutely.
And, learn together with you what you face as challenges in your day-to-day clinical practice, and how as scientists and technologists sitting in the laboratory will be able to support the oncologist in the forefront to provide the best affordable care.
Thank you, and you guys are already doing a great job, and thank you for joining and contributing in Impact India as well. And I look forward to real rigorous discussions that we've been having in our molecular tumor board. And the kind of work that you all are doing makes us, it really enables us and uplifts our platform to be able to discuss such complicated cases in a better way. So thank you for having me. And
Thank you so much.
hope you enjoyed the evening. Thank you.
Thank you. And we thank you all once again, all the attendees in India and overseas, like London, Malaysia, Bangladesh, Sri Lanka, and several countries across the world have shown a fantastic response, with Dr. Sewanti being a great teacher and a great speaker. She gives details on whatever topic you take up in cancer and in clinical practice. She has been doing wonderful. I have heard her many times, and I really like the way she puts it up like a story. And it is many people who are not from technology background are also able to understand. In the sense that even patients and caregivers also would be able to understand what you're trying to say here. So it's been a really great pleasure having you here in this precision oncology webinar, eighth lecture. And we have another interesting talk on comprehensive genomic profiling coming up in a few days from one of the renowned face in medical oncology and a Padma Shri awardee, one of the pioneers of medical oncology and a very senior person from India. We will be sharing those details shortly with everyone. And with this, if there are any further questions that we have not been able to answer here due to limitations of time, we will get back to you separately to your independent email addresses. Thank you all once again, and you all have a wonderful evening and a great weekend.